All right, good afternoon, everybody. Thank you for joining us for this press briefing. Appreciate you taking the time for us today. I am going to be joined a little bit later by Angie Ling, who's the Incident Commander for the Department of Health and Human Services, as well as Dr. Gary Antone, who's our Chief Medical Director and the Director of Public Health. And the first thing I want to emphasize or reiterate is to please ask people who have not been vaccinated to get the vaccine. We know from our experience here in Nebraska that the vaccine will help you generate the antibodies to fight off the virus. And that means it will help keep you out of the hospital and help prevent death. So if you haven't got the vaccine, please get the vaccine. If you have concerns about the vaccine, please talk to your healthcare provider about the vaccine, because it's our best weapon to be able to prevent those hospitalizations and deaths from coronavirus. We also today are going to be talking about additional steps we're going to be taking to help manage the staffing emergency that we have in our hospitals here today. So that's why we've got Angie Ling here. Now, one of the things that we did during the coronavirus pandemic earlier in the year and last year is that we set up a transfer center to be able to move patients around the state so that no one hospital or hospital system would get overwhelmed. And I want to thank all of our hospital systems here in the state because they have been fantastic throughout this pandemic. Not only have our nurses and doctors worked very hard to be able to take care of patients who are coming to the hospital, both COVID and non-COVID patients, but also the hospital administrators have been great working together to be able to manage the cases that we had. So last November, when we reached our peak at 987, we saw that the hospitals worked very well together to be able to move people so that we could provide that hospital bed or that ICU bed. And so as we're looking at this emergency right now with regard to staffing, that as we talked about last week, is not only involves the coronavirus patients, but also the 40% increase in other hospitalizations. We're again going to be setting up a transfer center to be able to make sure we're managing those hospitalizations so we can move patients around to different hospitals as need be so that we can provide that hospital bed or that ICU bed. And just for a reference sake, right now we are at 342 hospitalizations compared to the 337 hospitalizations that we were at last week with regard to coronavirus. And also, I forgot to mention when I was talking about vaccines, we also crossed the threshold of now over 1 million Nebraskans are fully vaccinated. So another milestone there with regard to getting vaccines out to people. We've crossed over 1 million of our citizens now have that vaccine. So with that, I am going to go ahead and call up Angie Ling, who's our Incident Commander for the Department of Health and Human Services. She's going to talk a little bit about the transfer center and what we've got going on there. Angie?
Okay, thank you, Governor. Good afternoon. I'd like to take some time to talk to you about current hospital status and the State Transfer Center. As you all know, Nebraska is an amazing state and has all walks of life. There are many different geographies, population densities, and cultures. What works for Omaha does not necessarily work for the Panhandle or Southwest Nebraska. We have 63 critical access hospitals in the state. Critical access hospitals provide very important and timely care to rural areas. They can range from a few hospital beds to about 25 beds and rarely have intensive care capabilities. Folks in rural Nebraska get very sick, just like the metro area, and when they need to be transferred to higher level of care, every minute counts. Our larger hospitals have more medical surgical beds and intensive care units. They also have multiple specialty services available with who are on-site for consultation. These services may include gastrointestinal specialties, cardiology, pulmonology, and nephrology, to name a few. Our larger hospitals are sitting at about 85 to 100% full at all times as of recent. Numbers fluctuate throughout the day. In the morning, the hospitals may have a few beds. By the evening, they have no beds available, and patients are staying in the emergency room because they have nowhere to go. We do have 342 COVID hospitalizations right now, but the majority of the hospital is full of other medical conditions. We have more patients in the hospitals now than we did during our surge last fall. This may be due to folks delaying their care over the past 18 months or increasing social environments. Regardless, the hospitals are full. We also have only a few hospitals that can take pediatric patients and even less that can take critically ill pediatric patients. While our pediatric hospitals aren't necessarily full of COVID patients right now, they are seeing an increase of RSV patients. RSV is a respiratory virus and can require advanced respiratory support, such as BiPAP and ventilator. Normally, this time of year, there are little to no RSV cases in the hospital. Another condition that could potentially stress our system in the coming weeks is multisystem inflammatory syndrome in children, also known as MIS-C. And this happens after COVID infection. While we may not see your kiddo in the hospital while they are most ill with COVID-19, they may develop MIS-C a few weeks later and require hospitalization, with about 46% of those cases requiring ICU-level care. I hope that information is helpful to understand the different types of hospitals and capabilities we have throughout the state. Now, another important message, we can have all the beds in the world, but if we don't have appropriate staff to take care of that patient in the bed, then the bed doesn't count. Our medical staff are hurting something fierce right now. We continue to ask them to work longer and harder. We need them to have downtime to recover and care for themselves, so when they are working, they are able to care for your loved one at 100%. Things that you can do for your medical staff is to be kind. I'm sure most people know or have a medical person in their family. Tell them they're doing a great job. Help them with their yard work when they're working endless amounts of night shifts. Buy them a coffee or just listen to them when they need someone to talk to. Protecting our medical staff will also keep or increase hospital beds so your mom, dad, grandma, grandpa, or child has the medical care that they all deserve. Working together, we can make sure hospitals and the people running them help deliver the care everyone needs. You can also assist with protecting hospital capacity by taking a moment to talk to friends and family about why you got vaccinated and encouraging them to get vaccinated if they're able. Medical research has proven that vaccination is the best defense against COVID-19. While no vaccine is 100% effective, the COVID vaccine has proven highly effective in reducing spread and severity of illness should you contract COVID. To help alleviate some burden from the medical community, the state has partnered with NOMI and is standing up a transfer center to assist in finding a bed for a patient needing transfer to a higher level of care for any medical condition, not just COVID. The transfer center is composed of nurses and will be available for hospitals to call 24 hours a day, 7 days a week. This will allow a nurse or provider at the sending hospital to be able to continue caring for the patients in the hospital while the transfer center is calling the larger hospitals to find them an appropriate bed. This transfer center will only take calls from Nebraska hospitals. Out-of-state hospitals should continue to call the hospitals directly. The transfer center is another tool in the toolbox to help the hospital systems out. It will be fully operational Saturday, September 4th. I hope this information is helpful in understanding our current situation in Nebraska. The medical community dedicates themselves to high-quality care, and we want to ensure everyone has the opportunity to receive that level of care at all steps in the healthcare continuum. Thank you.
Thank you very much, Angie. And then one of the other things that we can do to be able to help reduce the number of hospitalizations has to do with the treatment that we have here in the state that we've had for a while called the monoclonal antibody treatment. Now, there's a number of names that it has gone under, and I'm going to let Dr. Antone talk about this, but this is a treatment. It's an infusion. You have to have a doctor's prescription for it. We've got plenty of this treatment available here in the state, and we want doctors to prescribe it. Please, this is something that has to be done early on in the infection, so early on when you're being diagnosed. If you are getting diagnosed with COVID and you are a candidate to get this, please get it. It's something that will make a huge difference in the outcome, and I'm going to let Dr. Antone talk about that, but please, we want doctors to prescribe this to their patients so they can get this infusion, and again, it really reduces the number of people who are going to the hospital and reduces the severity of the disease if they do go to the hospital. So with that, Dr. Antone.
Thank you, Governor. And like the Governor said, I want to give an update on what's new with monoclonal antibody treatment. I think the last time we spoke here about that was probably back at the beginning of the year, and a few things have changed since that time, and I'll give that update. As we mentioned back when we talked about this last time, monoclonal antibodies are man-made synthesized proteins that neutralize the COVID-19 virus to prevent the disease progression. The FDA, under emergency use authorization, okayed 2 of these monoclonal antibody manufacturers back in November of 2020, and a third now has been authorized, another manufacturer has been authorized to use a monoclonal antibody. Now, we knew back then, we still know that these monoclonal antibodies are most effective when given early, and one of the updates I will give today on slide 3, I only have 4 slides, but on slide 3, there will be an update on how we can even use it earlier than what we have right now indicated for. So next slide, Brian. So there's 2 times that you could talk to your doctor or your doctor can talk to you about when monoclonal antibody therapy is indicated. The first is if you're symptomatic and you have laboratory confirmed COVID-19, and this is whether you're vaccinated or non-vaccinated. It's indicated for both uses. You have to be 12 years of age or older, and your doctor believes you are at high risk, such as you're over age 65, you have morbid obesity or obesity, whether you have chronic kidney disease, and so on. So that is up to the doctor to decide. The other indication is whether you're within 10 days of getting sick or having that positive test, and you are not hospitalized or requiring oxygen therapy. These were things that have been ongoing since around November of last year. Now, the studies have shown that these monoclonal antibodies, like the governor mentioned, are very effective. As a matter of fact, they've been shown to reduce hospitalizations, if you receive them, by 70% over the control groups. So it's great therapy. Outside of vaccination, probably our number 2 therapy right now. Now, the second time you can talk to your doctor can talk to you, or your provider can talk to you about monoclonal antibody therapy, and this is new, is that if you're a close contact exposure with someone who has had COVID-19 or at a high risk for close contact exposure depending on your job status, such as whether you work in a nursing home or a prison. Again, you have to be 12 years of age or older, your doctor believes you're at high risk, and you are not fully vaccinated, or you are fully vaccinated but have immunosuppressed immune system. So those are the indication. Now, this can be done either through an IV or a subcutaneous injection. And so the recommendations are if that IV infusion is going to delay treatment, to go ahead and do the subcutaneous infusion, which is much easier and simpler. And it is indicated for this under FDA EUA authorization. Again, the clinical trials for this, what we call post-exposure prophylactic therapy for monoclonal antibodies, has reduced hospitalizations by 76%. So again, very, very effective therapy. Next slide, Ryan. Last slide is how do you find, or how would a provider or how would a patient find where their closest infusion center is located. And there is a great website. It's been up for a long time, and it's covid.infusioncenter.org. And so you can go there as a patient and find out where your infusion center might be or where you might want to go, or your provider, or if you're in an emergency room or an urgent care center, they can go to this website and find where that site would be. And then they will get in contact with you. Sometimes it's done if you're affiliated with the health system, they just do it through the health system itself. If you're a provider or you're out in the rural areas and there isn't a health system, they can either fax your doctor an order, such as something like this. It's done for the CHI hospitals here in Nebraska, or they can get you the phone number for that infusion center to get that order in. Currently, Nebraska, I want to say, almost leads the nation in monoclonal antibody therapy. We took the lead in this early on. We had great leadership from our partners, our pharmacy partners, our hospitals throughout the state. We currently have 46 total infusion sites in the state of Nebraska. Last week alone, 241 infusions were given in Nebraska. Per capita, that's got to be one of the highest rates for monoclonal antibody infusions in the nation. And I just found out from our person in charge of ordering the monoclonal antibodies, we currently have 1,700 courses of antibodies that are available in the state. So supply is plentiful. It's just a matter of knowing what the indications are. If you're confused as a provider or a patient, just look up that website and talk to the infusion center themselves, and they will help guide you through that process so we can get this done. So appreciate the opportunity to talk about this again. Again, it's very, very effective therapy, as we mentioned here, and turn it back to you, Governor.
Thank you very much, Dr. Antone. Appreciate that. And again, that is a very effective treatment. That's why we want to stress to doctors, healthcare providers, that please get it to your patients early, because that will make a huge difference, as Dr. Antone was describing, the 77% difference or 70% difference when it comes to keeping people out of the hospital. And then speaking of keeping people out of the hospital, I thought I'd just give you an update with regard to where we are on the hospital capacity. So for adults, we are 72% occupied, and that means we've got 2,331 beds out of 3,234 beds, staff beds available. Pediatric is 70% occupied, 133 out of 191 staff beds. With regard to ICU beds, 77% occupied, 398 of 520 staff beds. Pediatric is 59% occupied, so 93 of 158 staff beds. So the total number of, we mentioned this already, of active hospitalizations for coronavirus is 342. So that is where we are with regard to the hospital capacity right now. And then one other thing I wanted to hit upon before we go to questions and answers is, again, just reinforcing a couple things with regard to masks on kids. I saw some of the news reports where I saw one doctor saying, now we're hearing about kids dying. We cannot have that sort of misinformation being spread. Again, I'll emphasize what I said last week, which is kids are no more at risk for the coronavirus than they are for the ordinary flu. And the numbers bear that out. So if we're talking about following the science, this is the science. So if you want to look back to the 2018-19 estimated flu deaths by the CDC for people 0 to 17 years old, that was 477. And the flu season generally runs September through May, so that's about an eight-month season. In 2019, the estimated flu deaths over again September to May, 434. So 477, 434. So far, throughout the entire pandemic, and these are national numbers from the CDC, January 1st through August 21st is 385. So you can see kids are more at risk for the flu than they are coronavirus. And our numbers here in Nebraska, specifically to Nebraska, bear out that same thing, that we have less than 5 deaths with regard to pediatric cases of coronavirus, and the same was true for the flu season, in the 19 flu season. So again, we don't mask up kids for the flu. There's no reason to mask them up for coronavirus. They're not going to be at risk. The argument is that kids spread the virus, which they do, but they also spread the flu virus too. And we actually have a higher percentage of people who are vaccinated. We're at 86.8% of 65-year-old and above that have been vaccinated for the coronavirus. That's higher than our typical 75%, for example, with the flu. So we're doing very well with regard to getting seniors vaccinated. They're the most vulnerable population. Also, I want to comment upon a news story yesterday with regard to the Douglas County Health Director, and want to remind everybody that the Douglas County Health Director has no authority to be able to quarantine or isolate anybody without coming through the state first. So just for all the school superintendents and school boards out there, just to be clear, the Douglas County Health Director has to come through the state to be able to get anybody quarantined or isolated. If you're hearing anything different, that information is not accurate. All right, so with regard to that, I will go ahead and open up to questions and answers.
Governor,
Yeah.
last week you said that the state would be looking at hospitalizations, COVID hospitalizations, the percentage of hospitalizations with COVID. I know we kind of had a little bit of confusion on, what the exact numbers were there. What percentage of hospitalizations in the state are COVID right now?
So given that we are only up 5 hospitalizations from where we were last week, they're going to be roughly the same numbers as last week. I don't have the number off the top of my head. I don't know if Angie or Dr. Antone have that, but the number really hasn't changed that much. It's up 1% from where we were a week ago. So the numbers you saw reflected in the chart last week are going to be relatively the same. Yeah, Paul.
Why are you taking, I want to get more information why you're taking the step about the
So the reason we're setting up the transfer center is the same reason we set up the transfer center earlier on in the pandemic. This time it's around, and it's always been around managing our hospitalizations. So the hospital emergency we declared last week, this is part of that program to be able to help manage that hospital staffing emergency, to be able to make sure we can move patients from hospital to hospital. Also, this is not a new thing. I mean, diverting patients from hospitals is something that happened pre-pandemic. So this is not a new thing, but with the staffing emergency we have right now, we want to set up that transfer center similar to what we had last year so that we can efficiently move people between hospitals or find that hospital bed for people who need that more acute care.
So were you aware of that case, and did that figure into decision-making, and now you think, I wish we would have done this?
So with regard to a specific case about somebody being moved allegedly to Iowa or whatever, I don't have any specifics about that case. It sounds like you've got more information than I do, but that did not play into our decision to set up a transfer center.
Governor, we have a hospital staffing emergency right now. Is this transfer center going to be taking away healthcare workers that are needed in hospitals, or is that already factored in?
So you mean with regard to who's going to staff the, no, so the staffing for this will be through a call center. We will have nurses here, both in the United States and in the Philippines. They'll be answering those phones. They'll all be trained to be able to help assist with the staffing, but they won't be taking away from our staffing needs or the staffing that we have here in the state.
You mentioned that one of the reasons for this was critical access hospitals don't have ICUs, so you have to transfer seriously sick people to bigger hospitals. Does it work the other way too? Can you create space in the bigger hospitals by transferring less seriously ill people to the critical access hospitals?
So can we move patients with less acute needs to other hospitals like critical access hospitals? Angie, do we do that? I don't.
We haven't done it before, but we've talked about it during the surge last time of reversing that. It's
Yeah.
an Intella.
So we did not do that during the surge we had with regard to the coronavirus last fall, though apparently those discussions were had with regard to the possibility of being able to do that. And so I presume that we'll continue to have those discussions to see whether it's appropriate.
Are we seeing any progress as far as the hospital staffing need being filled? I know it's only been a week since we made the declaration, but are we seeing any progress, and are there any next steps in mind to solve this issue?
Well, I think with regard to the hospital staffing right now, again, with regard to the coronavirus patients, it's relatively the same as it was last week. And to the point you just made, you don't magically generate a bunch of nurses. This is something that has to be trained. I don't know that after 1 week we've gotten any feedback, but I'll ask Dr. Antone, have you heard anything specifically from the CEOs or CMOs this past week?
When a few of the hospitals on their own voluntarily reduced their elective surgeries, a couple of hospitals said they did see some increase in their staff.
So what Dr. Antone can say is that when some of the hospitals voluntarily reduced their elective surgeries, they did see an increase in staffing to be able to help out the more acute people. Yeah, Andrew.
Governor, if, I guess you could reduce flu, by wearing masks, why not wear masks to reduce flu? You could save like 400-some lives by doing that.
So the question was, if you can reduce flu by wearing masks, are we going to make kids wear masks all year round? And, I guess I would just look to some of the experience that's happening in other countries. There's a number of other countries who are not requiring kids to be able to, requiring kids to wear masks in schools. In fact, because of the potential harm that could cause, I believe it's the Norwegian Public Health Institute has recommended kids not wear masks. But I know that, like England, Wales, Sweden, Norway, those are all countries where they are not masking their kids. I think there was a study in Sweden, though we'd have to go get the study specifically, I haven't read it, that actually found there wasn't a difference between transmission. I know there's a study from Georgia that showed between masking and not, or masking optional and masking mandate, there was no statistical difference. So again, you got to weigh the cost-benefit trade-offs here. So I think at this point, not knowing what the harm that could be caused by masking kids is, and again, given that we have operated our schools for how many decades without masking kids during flu season, that's what people have decided that is the most appropriate course. Yeah.
So I guess basing my question off your answer there, do you think LPS is doing the wrong thing by requiring masks for their students then?
I am 100% against mask mandates at any level. Yeah.
I know Andrew mentioned some of the other hospitalizations that we're seeing besides COVID. She specifically
So we have RSV discharge data, for example. I think I shared that last week. Last week, I think we had a total, this will be ballpark, of 33 pediatric discharges. I think this week was 39 discharges. I'm sorry, is that right? That's right, yeah. So those are the numbers we have for this week, but we can follow up and get the total. I think the total last week was 44 total, 3 of them being pediatric. When I say pediatric, it's like 0 to 5 or whatever. But we can get to that specific data.
And then as far as the MISC, the kind of after effects.
Do we have that other data? I don't know we're actually seeing that yet. Yeah, so that's really kind of a hypothetical. Yeah, so we saw it last year when we had more pediatric cases in the Sterling surge. Maybe we can get that historical data. Yeah, Martha.
Can you talk about what harm there is for requiring kids to wear masks?
So
Is there
there's been a number of articles. In fact, we're going to hand out some articles here about this. We've got articles from NPR that talks about how kids are no more at risk for coronavirus than they are the ordinary flu, and also one from New York Magazine, and some of the doctors there talk about some of the potential harm. So I'll refer you to that New York Magazine article. There's no studies, so I want to be clear. There's no studies that specifically, at least that I'm aware of, that specifically define the harm for kids wearing masks. These are just some of the concerns that doctors have, and obviously enough that the Norwegian Public Institute of Health has decided recommending against kids wearing masks. So I don't believe that there's a consensus with regard to this. But one of the things that's out there, and you can read the New York Magazine article about some of those concerns those doctors have about it. And I will tell you one other thing, just talking to my friends in the construction industry, that OSHA puts more restrictions on workers in the construction industry when they wear a N95 mask for 30 days. So clearly OSHA believes that there's some issue with regard to long-term wearing of N95 masks in that environment. So again, I think that there's enough there that if we went for decades and decades without masking kids for flu season, why would we do it now?
So are you opposed to children wearing masks?
I believe it should be the parent's decision with regard to children wearing masks. So I think it should be mask optional. So if a parent wants to mask up their child, I think that should be their choice to be able to make. I'm against mandates for masks in any setting, especially schools, since the kids are least at risk. Andrew. Sure, Dr. Antone.
And the question is there any indication that wearing masks last year suppressed kids' ability to develop antibodies or protections against RSV, and that's why we're seeing an RSV spike?
Andrew asks, is there any studies that show whether when the children wore masks last year, whether that did decrease the amount of antibodies that they might have developed against the RSV virus, and that's why we're seeing a surge in the RSV virus now, a little earlier, quite a bit earlier than the normal RSV season. I have not seen data on that. It's a good thought on maybe that's one of the reasons why we have seen that RSV surge, but I can't give you any data on that right now, Andrew.
Is that one of the considerations about masking, is that kids don't develop immunity?
Andrew asks, is that one of the considerations of why kids shouldn't wear masks? And to my knowledge, that is not a consideration.
Robert, you mentioned with the Douglas County Health Department quarantine and isolation that she doesn't have authority to do that, that has to go through the state to be approved. Last week, whenever we were discussing children wearing masks and how that could affect other kids, you said, quarantine is always an option. So is that something that the state is going to be approving whenever these cases do come up then?
So when I said that the Douglas County Health Director does not have the authority to be able to quarantine or isolate without coming through the state, that is exactly accurate. And then the follow-on question is, well, would the state approve those? And we actually have some guidelines set up for how you would do that based on the number of contacts that children have. So we have guidelines set up already that we would use if there was any request for quarantining or isolating any kids in schools.
Governor, have you spoken to decision makers, education decision makers on a local level about your stance on masking kids? And if so, what's their response been to you?
So I have not spoken directly with any superintendents or school board members with regard to it. I've been doing what we're doing here, just stating my general position about it. But if somebody was interested in talking to me, I'm happy to talk to them as well. Andrew?
I'm a little confused. You said we have 70% hospital bed capacity?
No, that was percent occupied. So the reverse would be about 30% capacity.
But Angie just said that we're full.
There are, I'm sorry, what, Angie?
The difference is the critical access hospitals account for those
Right.
beds.
So the critical access hospitals have much of the capacity, what we're talking about, when Andrew was talking about hospitals are full. So again, that's one of the reasons for the transfer center to be able to make sure we're balancing out those needs. And again, so just also, so we're also clear, generally hospitals operate at very high capacity. They generally operate at that 90% to 100% if they can manage it that way. So obviously, we've asked people to take a step down during the pandemic when we were restricting things last year, and now more people coming to the hospital, so we have to just take a different approach to managing that, and that's one of the reasons for the transfer center.
But if your North Star is hospitalization rates, wouldn't you be, I guess, gauging those on the most critical needs? Say if somebody got an accident, where they could get hospitalization?
Well, right, that's why, one of the reasons why I cited the ICU bed capacity as well. So again, critical access hospitals generally don't have that ICU bed capacity. And what were the numbers I just cited here with regard to ICU? Right now, our adult ICU capacity would be at 23%. We've got, we're occupied right now 398 of 520 beds, so that's ICU capacity. And then the pediatric ICU capacity is actually, would be at 41%. So again, robust capacity there as well.
And when do you bring back things like the dashboard, Test Nebraska, and some of the other DHHS?
So again, we're going to continue to monitor hospitalizations, and we'll take steps as we go forward. But again, as I said last week, just a reminder, it was when we reached that threshold of about 10% is when we took additional steps. So we're at 342, I think, last week overall. It was, if you add everything up, it was like 4,200. So it'd be about, at that point last week, I think Angie did the math, it was 420, 10% number. Yeah, Grant.
Transfer center, NAMI, did that require a new contract with the state? And if so, how much is it for?
No, did that require a new contract with the state? Can you? It was added, it was an addendum onto their current contract, and do you have the approximate dollar amount?
It'll be approximately $200,000 a month.
So it's approximately $200,000 a month.
And that entity is which?
Nomi Health?
I thought their contract expired June 30.
We had dollars that we were already working with them for things that we weren't, we didn't use.
So, right, so Fred said, I thought their contract expired June 30th. We had some dollars that were within that contract that allowed us to be able to expand it.
Left over.
Yeah.
On the statistics you gave us about the number of kids who died from the flu, if one of the points of masking is to prevent kids from spreading COVID, how is that relevant?
That's my question. So Fred's asking if the number of deaths, how is that relevant to kids that spread COVID? Again, I think that everybody can spread the coronavirus. And here we are selecting kids to mask up when we don't do that during flu season. That's why I'm against that.
But I mean, if the risk of kids not being masked is not that the kids will succumb to COVID, but that they could spread it, then how is the number of deaths of children due to flu relevant to that?
So, okay, so well, I guess what I was pointing out with regard to the risk of kids dying from from coronavirus being relatively the same for flu, we're not protecting the kids is my point, right? So, we're, right.
The argument, as I understand it, is you're protecting.
Yeah, and so the argument is then that you're preventing them from spreading it to somebody else. But those other people can go out and take other steps to protect themselves. They're adults. So they can go out, for example, and get the vaccine. They can take other steps to protect themselves. And that's why I think this should be a choice of parents to be able to decide whether or not they want their kids masked. And on that point too, regarding another statistic along those lines has to do with hospitalizations, and the hospitalizations also for both flu in prior years. Generally, CDC estimates about 52,000 hospitalizations among pediatric patients for the flu, and the hospitalizations for the entire pandemic have been about 52,000 for coronavirus. So again, if you're talking about an 8-month flu season where you get 52,000 hospitalizations for flu, and you look at from January 1st to August 31st, about 52,000 hospitalizations, you can see again, kids are no more at risk for the hospitalizations for coronavirus than they are the flu.
Governor, Taylor Gates shared a graphic about 5 days ago showing that this time compared to November 2020, COVID hospitalizations went down, non-COVID hospitalizations went up from 68 to 89%. And I'm wondering what accounts for that difference in the non-COVID hospitalizations. What are you seeing?
Yeah, so with regard to, the question was, why do we see so many more non-COVID hospitalizations from where we were previously? And we don't have any hard data with regard to that, but we can speculate that it could be that it was delayed care, that people didn't get the care they needed last year, and so they're seeing it in more severe symptoms this year, whether it's cardiac systems or cardiac events or stroke events or something like that. It could also be that people delayed their care last year and now they're coming back to get that care. So there could be a variety of reasons. We don't have any hard data, but we can observe that we are seeing more non-COVID hospitalizations now than we were previously.
Does that concern you?
Well, certainly the non-COVID hospitalizations are what's driving a lot of this with regard to the staffing emergency. That, again, we're up 40% from where we were, say, in November of last year with regard to non-COVID hospitalizations. And so we got, that's the 800 more that's people in the hospital, that's non-COVID that's driving this.
We have time for 2 more questions.
A couple more questions.
Governor, why are we comparing numbers from right now to the peak of their pandemic rather than this time last year? What's going into that decision? I mean, in theory, we could, for all we know, be heading towards another peak in November.
Right, so the question is, why are we comparing ourselves to the peak in November versus maybe this time in August last year? And it gets back to that we were looking at the peak of hospitalizations for coronavirus and the most stressed our hospital system was at the time. We can certainly go get the data for August of last year if that would be of interest to you. But given that I already said 1 million Nebraskans have been vaccinated, and we know the vaccines work to keeping people out of the hospitals, we just don't believe that you're going to see the same level of hospitalizations that we saw last year because we had unvaccinated people. Last question, Martha.
Okay, and this is for Dr. Anton, about the antibody therapy. Would you recommend that people, how do you compare this therapy versus the vaccine? If you don't get the vaccine, you could say, hey, if I happen to get sick, I'll just go get this treatment. How do they compare as far as cost, as far as side effects, et cetera, et cetera?
So Martha's asked the question that a lot of us have thought about, and that is if monoclonal antibodies are this effective, why get the vaccine? Well, the reason is because monoclonal antibody therapy is good for only a short period of time. When you get the vaccine, your body makes these antibodies not only at the time you have a disease, but if it comes back, and then you have those antibodies. So vaccines are for a lifetime, or maybe might need a third dose or a booster dose. We're trying to figure that out right now. But it's that your body's able to make these rather than us giving them externally. And so that would be the main reason. If I was to rank the therapies for fighting COVID and 10 top ones, I would say 9 are the vaccine and 10 might be the monoclonal antibodies.
What's the cost of this therapy?
You know, I'm not certain of the cost of the monoclonal antibody therapy, except to say that it's covered by the federal government.
Have we studied the effectiveness of it with some of the variants that we're seeing now, or was these studies done last year when we didn't have the Delta variant, things like that?
The question was, have we done some recent studies that show how effective the monoclonal antibodies are good against the new variants, and such as the Delta variant? And we do have that data. They are very effective. Even the monoclonal antibody that wasn't effective against some of the new first variants, like maybe the Brazilian variant or whatever, are very effective against the Delta variant.
All right, folks, thank you again for joining us with this press briefing. Appreciate your time here today, and have a great rest of your day.